Sorry we're late. A few technical issues. Welcome to the first live stream in over 2 years.
It must be.
Must be over 2 years now. So, sorry, no, Kathy didn't remind me that you did one last February.
We did the one when no one could see us, and now we're doing the one when no one can hear us.
Yeah, that's true. Yeah, absolutely. So so welcome.
Let us know if you can hear us.
Yeah, somebody give us a wave, say hello, do anything if you can hear us or see us or not. Well, you won't be able to tell us if you can't see us or hear us, but you know, it's been a while. Sorry, guys. Right, I'm Lindsay, volunteer for East Cornwall, West Devon, Crohn's and Colitis UK.
I'm Jane. I'm also a volunteer for Crohn's Colitis UK.
And I'm Kathy, IBD nurse at Derriford.
Oh, wonderful.
You're on and you're working.
Apologies for the noise in the background, it was just a test. So, we've got a couple of questions already lined up, but get typing, get sending us some questions.
Stacey said hello.
Hi Stacey, thank you very much. It's nice to know people are out there.
Graham from Tenerife.
Hi Graham, all the way from Tenerife. Wow.
Ask him if he's been arrested yet.
What? You're the one on camera.
I never ask you that, Graham, but
He'll know what I mean.
okay.
Okay.
Sorry,
Let's crack
viewers,
on.
hopefully he hasn't.
For the first question we have here is, are there any new IBD medications on the horizon? So there are a lot of new medications that we aren't yet using on the horizon, and that we've only just recently had agreed by various committees. And NICE and National Institute for Clinical Excellence have agreed to use some further their biologic medications. Generally speaking, at the moment, as you all probably know, the standard biologic medications are infliximab, adalimumab, vedolizumab, golimumab. We have some fairly new kids on the block, tofacitinib. Why they name them in these manner, I do not know. And filgotinib. And the last two are work in a slightly different way, although they're still biologics. But the nice thing about them is they're a tablet, rather than having to inject yourself or give intravenous. So yeah, there are some relatively new drugs on the horizon that we haven't used yet, and we're just beginning to use. And there are some other ones out there, and they are all kind of biologics, so they'll all do much. They'll all be, particularly good for severe colitis and Crohn's disease.
Sorry, guys. I am paying attention.
That's quite all right. So yes, there's a lot of I think the main direction of travel from now on is going to be biological drugs, because they're hugely. We still rely very widely on azathioprine and mercaptopurine. They are still the best evidence-based drugs for colitis, not so good for Crohn's. On the whole, we tend to use biological drugs for Crohn's.
Graham says not yet, he's been good.
Good to hear, Graham.
Oh dear, there's a story there. Okay. Do feel free to.
So the new biologics that are
Trip
coming
in with
in,
any- yeah.
are they going to be along the same line of infliximab, or are they going more Stelara kind of?
Yeah, no, I mean, really, I think, there's so many now across rheumatoid arthritis, bad psoriasis, Crohn's colitis. They're being used for so many different conditions on there. And it's nice to have some that are tablet form, because up until now, everybody's had to have an infusion or injection.
Yep.
And there are a lot of people, especially very young,
Don't want to do the injection.
young women, young men who are particularly needle phobic, and if they're at the beginning of their journey, they might feel quite threatened by that. It's quite nice to be able to give them a tablet if possible. So
Of course, there's other people out there that just can't tolerate anything, aren't they, Kathy?
there are a few like that, Lindsay. Yeah, they're few and far between.
And we are a pain in the backside.
Um,
But if you're one of them, you're not alone.
you're not alone.
Not alone.
So the next one we've got is, does Derriford do faecal transplants?
Yeah.
The short answer is no.
See, I did ask one of the surgeons about this quite a while ago, because I'd seen a hospital up in Scotland. They'd done faecal transplants, and they'd done the first ever bowel transplant.
Yes, so bowel transplants are have been well they're quite evidence based. They're not used particularly. I mean, they're not being done particularly in the UK.
No, they're
There's
quite
a lot of
dangerous,
centres.
aren't
They
they?
can be. There's
Yeah.
a lot of centres in America that are doing them. We've had one or two patients who've had small bowel transplants who we've sent up to Cambridge, one other centre, for consideration of that. But those are people that would really be significantly have intestinal failure, so they really are at the end of the line.
I was going to say that the case in Scotland, he literally had. He was going to die.
Exactly.
He wasn't even absorbing the tube
No,
that he was
exactly.
having.
So they need to be patients will be TPN, which is
Yeah.
nutrition through a line in your neck, and they would be failing even that.
Yeah,
for that.
that's like
What does
he was,
TPN stand for?
Total parenteral nutrition, which they give through your neckline or a line in your arm. Fecal transplants, the evidence for that is actually for C. difficile infection. So it's a nasty bug.
Yeah.
Yeah.
And the best evidence for them is in that particular type of scenario, not so much for IBD. So it's more in people that have resistant C. difficile infection. There has been some success, I believe, in fecal transplants, but I don't know a lot about that really.
No, I did look into, because you do, when you're desperate, you look into just about everything that's on the market and what's going on in all the other countries, and it didn't seem to have a great success rate with Crohn's, so it was something I sort of kind of dismissed quite quickly.
There are a lot of quite quirky things, aren't there, being done in various centres. Like you say, if you're desperate, you will want to look at everything.
Absolutely.
But it tends to be better for infection rather than IBD.
How have we got on with the stem cell research going on up in London?
I believe that trial
It got
ended
halted.
because that poor lady died in
yeah.
Exeter. Yeah, so that's
So
been
they never
halted.
restarted it.
They didn't restart that one. It is still being done, in America.
I was gonna say
There
the
may,
Americans,
I'm not
yeah.
sure, they may be looking at it again in the UK, but I think since that lady passed away,
It was very sad.
it's a big step, isn't it?
Yeah, of
Huge.
course, I was meant to be going up there, wasn't I, until I fell pregnant with Maisie.
Yeah, and that's cured you, having a baby, as
Well,
it often does.
Something about cured, but it's about half of it in a bit. Should we say half of it in?
Yeah.
Half. Yeah, the other half still questionable.
I don't know how to answer this next question. I don't know the answer, so it might be a Google.
Okay.
I have patches of dry skin on my hands. I've tried hand cream. I read somewhere you can get athlete's foot on your hand. I actually don't know that.
I think that question actually came in for when we were going to do this in September,
Ah.
and then we didn't because unfortunately the Queen died, so we cancelled it.
Yeah.
Okay. I mean, the only link that I'm aware of with skin, and a lot of people with Imraldi and Humira, adalimumab, all the same drug. Some people tend to report quite dry patches of skin on their hands and their body, and it's quite difficult to quantify dry patches because people get it anyway.
Yeah.
And a lot of people do get very dry skin at different times of year, and a lot of people with Crohn's have eczema, and
I was going to
you've got
say,
all of that
I've got
type of
the
picture.
lichen siplets,
Yeah.
which I think they associate to the iron deficiency, which is caused by the Crohn's.
So there's so many things that
Yeah.
cause that sort of problem. There's a definite link between a condition called palmar-plantar psoriasis, which
Right,
might have been
okay.
what the person was thinking about. And that's a condition, a very nasty skin condition of your hands, psoriasis of your hands and your feet only. But it can be really, really quite debilitating with deep fissures in your hands and your feet.
God.
And there's some links. Sometimes people find that certain biologics have triggered that, but not for most people. So
Yeah.
I would say, on the whole, with the dry skin thing, it's often not related to anything.
I can't say that I've ever had any skin issues from the biologics.
I do have skin issues, but not from the medication.
Yeah, I was going to say I've
it's
got
from
skin
the IBD.
issues from the Crohn's,
yeah,
but
absolutely.
not from the medication. No.
Yeah, absolutely. So
Because the Crohn's and colitis itself can cause so many different skin
yes.
issues, bone issues, teeth
Lots and
issues.
lots of
It's so
things,
yeah,
so many,
many issues.
That you wouldn't think are related.
No,
Yeah, no, exactly.
I think it's why diagnosis is still so difficult because people present so differently. I'm pretty sure nobody's been told it was their underwear like I was told originally, but you know.
Okay.
Yeah,
Okay.
sure Marks and Sparks would be really
Yeah.
pleased about that. But yeah,
I think think the other thing with Crohn's and colitis is you just get this blanket approach, don't you, by some other healthcare professionals, who whatever you go to with your GP, it's like, oh, it's your Crohn's, you know, or it's your IBD, and that everything's lumped together.
I have to say, this is where Kathy is my angel, because I get that a lot, and I have to email Kathy and say, I'm really sorry, but I need this, and I've been told can't have it. Just they can't be bothered, basically.
And it is difficult. I mean, you know, nobody knows if things are related, and it's just a matter of ruling one thing out at a time, isn't it, really?
Yeah.
Most definitely. I react to lots of medications. Recently, I suffered for 50 odd years with, I thought, UC. Recently been told it's Crohn's. And I do react to a lot of medication, which iron tablets, anything makes me nauseous, upsets me. So, and that's only in the last 10 years.
Yeah,
So,
it's funny, isn't it?
yeah,
Yeah,
and I put that all down to IBD,
Yeah,
and I'm sure it must be.
yeah. Oh, Wendy Wu.
Yeah.
Hi, Wendy. Hi, ladies.
She came to our coffee morning as well.
Oh,
Did she?
yeah, so that seemed to go quite well.
Yeah.
Yeah. Was it the first coffee morning you've had?
Yes.
First one for a really long time. We used to hold them at Dunelm Mill,
Oh, yeah.
but we've moved to Costa now, so
We've moved up in the
we've moved up.
And
Sorry,
to
Dunelm.
Saturday.
or downs, but depending on how you
Yeah, we changed to Saturday.
Yeah, we changed to Saturday, so more people
many
can
more
make
people
it.
can come. Yeah.
Oh,
And the
Especially
last
me.
one.
And actually, yeah, just on that note, if anybody does want to come and join us for the next coffee morning, it's a Costa Coffee at Marsh Mills.
and Lindsay's
One
paying.
in Wren's
Yeah.
the
and
Wren's kitchen, not the other one at Marsh.
it's by the one at it's the one at Wren's Kitchen, not the other side. And it is on the 25th. Sorry, I'm looking over there. 25th of March, because we've only just decided it. Sorry, my mind disappears. 25th of March. Come and join us. 10:30.
Yeah.
Is it 10:30?
Oh, there's Gwen. Hi, Gwen.
And
Julie and Sam. Sam, how's Sam these days? I hear Sam's doing
Questions?
very well. Oh, sorry.
Tell them.
Yeah.
Oh,
Ask questions.
Ask any
Any
questions
questions for
if you would
Kathy? Come on.
like. Yes, do feel free.
Oh,
Okay.
Wendy Wu prefers Costa.
Okay, so the next call in or ringing is, I've recently been on my Captopirin and been told to increase my dose. Why is this? Very good question. So when we used to, years ago, when Shaz was around on the Captopirin,
Shaz is still here. It's okay.
when Shaz was a young girl,
Oh, well, there we are talking a while
That
ago.
long time.
that's right, yeah. Years ago, when we gave azathioprine and mercaptopurine, we knew roughly what dose would suit people. So it was a 1.5 milligram per kilogram dose, or 2 milligrams if for azathioprine. And that's how we measured it. You know, we didn't measure it. We just gave people that dose, and we'd measured their bloods, monitored their bloods, and if their bloods weren't right, then we changed the dose, reduce it, up it. Now we have the benefit of doing a drug test, which we've done for quite a long time now, which looks at actual levels of the drug, and it's incredibly helpful because sometimes you can predict if drug levels are too high. You can predict those people that might, for example, have problems with their liver, might drop their white cell count. So it's an early predictor. It's a good test to have. So if you've had blood tests done and your levels have come back as low, then that means you're on too low a dose, and we increase it. You should have been told why we were increasing it, so sorry about that. But generally that's why. So we would do a blood test, it would be a low level, and we'd say increase it to this dose because your level's low. And conversely, if your levels are too high, we would reduce it. So yes, I think it's changed how we use mercaptopurine and azathioprine, and I think we can be more efficient now, which is good.
Yeah.
Gwenny's asked, can we do a meet in Cornwall? We could, I guess.
Yeah.
Like a coffee morning.
We could,
Yeah.
or maybe we could look at the Cornwall show's coming up in June or July, isn't it? So maybe some of us could pop down to that and do a coffee at a stand
Or
or
a
something.
stall or something, yeah.
Or a smoke.
I
I don't know if we can put a stall up. It might be a bit late to get one. We might be too late to get one
Yeah.
because they get
I
full.
like
Bring all the
Costa.
dog banners, the doggy thingy bandanas.
But
Sailing
failing that,
has
we
walking
can always
ones.
do a
Walking
coffee
ones, yeah.
morning
Yeah.
in Cornwall.
But yeah, we can certainly look into it.
We can find a
absolutely.
coffee place.
Yeah,
And we'll bring dog bandanas
and we'll
for
do a
Kathy.
stall with dog bandanas.
Can we bring the dog?
Yes.
Yeah.
Oh my god.
We can
No,
all
I'm
bring
not
our
taking
dog.
that. No. Take yours. Yours is lovely. Yours is well behaved.
She's just very old.
Oh.
Right, okay, next question. I've been told I have IBS as well as IBD. How do we know the difference? Another good question. So IBS is a syndrome and a collection of symptoms that doesn't cause a disease or doesn't cause damage. So people can feel really awful with IBS. They can have very similar symptoms: diarrhea, pain, bloating, intolerance to foods. Very, very similar to IBD.
Yeah.
But the difference is when you do a scope or when you do an MRI, it's normal. So that's the kind of major differences between IBS and IBD. So the way that we determine if someone's having a flare up, and is it a flare or is it just IBS, is very easy these days. It's a sample for fecal calprotectin, and that's like having, well, it's used in place of a colonoscopy, so that we don't have to use so many colonoscopies. We don't have to do so many flexible sigmoidoscopies.
We're all in favour of
We're all in favour of that. Obviously, you need them from time to time, but you know, it's a very helpful test because if it's normal, you can more or less say this is IBS. If it's very high, you can say this is your IBD. Yeah. And symptoms for IBS can be managed, you know, conservatively without the need for any major treatment.
Yeah. It is hard to tell the difference, but when you're in it. But I think, to be honest, if you're in pain and you're suffering, you need to look for help anyway.
Absolutely.
It doesn't matter whether it's IBS
and even
or
if it
IBD.
is IBS, you know,
Yeah.
there's lots of treatment you can
Yeah.
have for that. So it's just helpful to know we don't want to be giving people strong drugs for
No.
IBS only. So
That's it,
yeah, it's
yeah.
a really helpful test. Is there a question there?
Yes.
Something's making these guys giggle. What are we looking at?
Stacey is asked. The reason we were giggling was because Gwenny said we can go to hers in Cornwall. Probably. That's really
Bless
sweet.
her.
We probably could do that. But Stacey has asked. I get asked a lot, which you could answer, please, Kathy. How long do you usually try managing with medication before surgical intervention is required?
Yeah, okay. So Stacey is our new lead stoma nurse.
Oh,
Yeah.
Oh, hi,
And
Stacey.
she's,
I've not met you yet.
she's absolutely lovely. And she's been in the job for a little while. She's got lots of surgical experience, and she's just taken over from Lisa. So she's now running the show.
Right,
Yeah.
okay. I'm sure we'll
Um,
meet soon.
So yeah, we work together quite closely. In answer to your question, I think on the whole we tend to give everything a go before surgery, and that would very much depend on the disease. If it's colitis, then we would try everything we possibly can. But we know that for colitis you can have a colectomy and it is ultimately a cure. We can't do that for Crohn's, so we would try and at all costs give medical therapies. Unless it's a simple small section of Crohn's of the small bowel and somebody particularly wants an operation, that that, you know, you don't have to go through the gamut of tons of drugs if that's what you want. But certainly if you had extensive Crohn's, if you had small bowel, large bowel, perianal Crohn's, you know, you can't chop out all your whole bowel, sadly. So then we would
It is
we would give all medications a go. And I think, to be fair, for both conditions, most people want to give all medical therapies a go before they go for surgery. It's not a quick option often, surgery, so yeah.
It also doesn't
Quite a while,
always fix it.
Stacey.
Yeah, it doesn't always fix it either. So if you can try medications first, stick with it.
Graham Westall, I was recently in a restaurant and I got, oh no, sorry, that was, and I got
Nope.
arrested.
No. Go on.
This one I'm just writing, but I can read it to you. Amy has asked, my 12-year-old daughter has Crohn's colitis, stroke colitis, so maybe they're not sure yet. Was just wondering what vitamins you would recommend.
Sorry, my 12-year-old daughter's got,
Well, it says Crohn's stroke colitis, so I don't know if they haven't diagnosed which it is.
No, they can have both,
But
can't they?
or
Yeah.
you can have,
You can have Crohn's
or
colitis.
non-diagnosed even, can't you? Or
You can
whatever
have
they call it.
Crohn's colitis as well, can't you?
So she's asking what vitamins would you recommend?
that's a bit tricky. It would, the best thing to do really in that kind of situation would be to have all your vitamins tested. So, you know, if you're 12 and you've got small bowel disease, then they normally do what we call a micronutrient screen. And that would be looking at all your nutrients, and then we would replace it
Right.
with quite heavy duty.
Yeah, because you have to be careful, don't you? Because some vitamins you can overdose on, and it causes.
Yeah, so I think
D
for a
is one of them,
12-year-old,
isn't it, as
you
well?
would want to know what are they deficient in.
Yeah.
So I would ask for them to do a micronutrient screen, presumably they're probably under Derriford. You know, if you literally just want a multivitamin, then just take a good something like a multi-bionta. They do a good multivitamin.
Right.
If you just want to take that, should be okay for children. Just check.
And so they
chemist.
do kids ones out
Yeah.
there as well. So
You're not going to do
maybe one
anyone
of them would
harm
be
by
safe,
having a
yeah.
multivitamin, but if you're, you know, that they should be checking micronutrients and stuff in children that have been diagnosed with Crohn's.
Is that quite standard? Should they do that like normally? Is it a standard procedure? Or?
Yeah, normally it is, but they do have a lot of problems. We have a lot of problems across the board with lack of dietetics, and you know
is
we've
hard to get in,
we've lost
yeah.
our dietitian recently,
Yeah.
and we've now going to take on another one in April, Paula. I think someone's mentioned Paula.
Yes, but first of all, Graham has asked, does colsevelan
Colicevalum.
Cholesterol, right, cause an increase in cholesterol levels? I always had low cholesterol, but recently GP suggested statin. I started taking colicevalum about 2 years ago.
Yeah, it shouldn't do. It shouldn't do. It's a bile sequestrant. In theory, it's for really problematic diarrhea, and we give it if Imodium hasn't worked. I'm not quite sure, Graham. I would probably ask. I can look into it for you. I can look into it and find out if that's likely.
So does that,
It's strange you've suddenly got a high cholesterol if it's been normal all along.
Yeah,
or has it been
So
building and you didn't know?
recently GPs. Well, she started taking this about 2 years ago, but now the GP suggested a statin. It's just because you're old, Graham. Sorry.
She's allowed to say that because she's old.
I'll look into that for you, Graham, and I'll email you when you're back from your holes.
Wendy said Paula has prescribed me Stexerol D1000 IU times 3 a day, as well as the Accrete D3.
Right.
But my GP has prescribed only one Stexerol a day. Should I get back to Paula or the GP? Who's Paula?
Yeah, Paula is the dietitian who's now coming to work with us in April, but she would have seen Wendy because she's under the nutrition team,
Right.
and Paula was under the nutrition team. I'd have to look at your level of your vitamin D, Wendy. I mean, if your vitamin D is very low, then the treatment dose would be 2 tablets a week for 6 weeks. But I couldn't say without looking at all your bloods. But I would certainly get back to Paula because she's absolutely brilliant, and I would go with what she says 100%.
Right. Hannah's asked, did Julie pass on my message about having my final surgery?
Yes, she did. Judy, are you home now, Hannah? Is Hannah home?
She doesn't say.
Oh, I hope you're home.
She says, hi Kathy, how are you? Did Julie pass on my message about having my final surgery?
Yeah, you're not still sat in Derriford, are you?
Oh, if you did, you went home very quick. Anyway, congratulations. I'm so pleased. Amanda Harris.
Yeah, man.
She's on there.
Yeah.
Amanda
Amanda's a
Harris.
biologic nurse.
She's fabulous.
Yeah.
Yeah. Amanda and I share the office.
Right. I think.
Many
I've
a
seen her
fun
many
time.
times when I've
Many a
come in,
fun time.
Never go in to see Kathy on a Friday. Just
Haven't got any more at the moment.
Why? What happens on a Friday? Thanks, Heather Jenkin.
Oh, she says, Hannah says, yes, I'm home. I came home Saturday. You know what I'm like.
Oh, bless. I didn't even get to see her. I'm pleased you're home.
And Heather asked, is that Dr. Paula? I've just lost
Who
it.
does TPN stuff?
Yes.
Yeah, that's absolutely right. Yeah. I've got another question here. Is IBD hereditary? God, these are really quite challenging questions. I've got my work cut out for me. Not
That's
like
the
what's
ever-
Imodium do.
no, ever going question that one, isn't it? It's,
Yeah. So
There's no easy answer
we
to that,
haven't
is there?
well, they haven't, the clever people haven't identified a gene in ulcerative colitis of any sort, as far as I'm aware. So we tend to talk of it being possibly familial, because you can't, like if someone has cystic fibrosis, they have a gene, they carry it, they pass it down. There is a gene that I believe 30% of people with Crohn's carry, called the NOD1, or it might be NOD2, don't quote me on this. But that was only 30% of people have it. So you can sort of say there's a genetic link, but you can't say it's hereditary. You can't prove that if two people both had Crohn's, for example, they would have a Crohn's child.
So they recently did a paper on it, didn't they?
Yeah.
That they'd found a gene that if you've got that gene, you are, shall we say, predisposed to getting Crohn's.
Yeah.
So it doesn't mean you're going to, a bit like the cancer one, the cancer gene, but it doesn't mean that it also passes on.
Yeah.
It's a rare gene
Yeah.
they found that could be in random people. So somebody, you might have no one in your family with it,
Yeah.
but if you've got that rare gene, then you
Yeah.
are predisposed.
I mean, it's
to
a
it.
really interesting, topic, because ulcerative colitis, it's been around for so many years, and they still haven't really. They can't work out what causes ulcerative colitis. Crohn's, they know a little bit more about, I think. And there do seem to be more genetic links with Crohn's. But even now, we don't know an awful lot really about why
I
people
think that's what makes
develop
it so
any
hard
of these
in trying to cure it, doesn't
Yeah,
it? Because
absolutely.
everyone's so different
Yeah.
with it. Everyone's got it differently at
Exactly.
different ages.
And the same with
Yeah.
rheumatoid arthritis,
Yeah.
and it's just. I can ask you this next week.
But if one biologic doesn't work, why would a different one? Can you explain how they work in different ways? That's Gwenny.
Ah, okay. So all biologic drugs they don't work on the same mechanisms, shall we say?
Right,
They
okay.
target different proteins and different the way your immune system works.
Right.
So some biologics are called anti-TNF, some are called JAK inhibitors. I won't,
I've not heard that one, but yeah, okay.
it's a little bit,
Okay.
it is quite, it's
Yeah.
a very complicated subject, isn't it? But infliximab and Imraldi are the commonest ones, or the ones we use the most, and vedolizumab. Vedolizumab works in a different way to infliximab and Imraldi, and it's gut specific.
Imraldi was Humira, is that?
That's right, yeah.
Okay.
So vedolizumab we give to people if they have other illnesses, for example, sometimes. Lots of different reasons. We often give vedolizumab to people that are like over 80, because it's sort of seen as a bit of a nicer biologic.
I was going to say there was literally
less-
no side effect whatsoever from that one when
No.
I tried it. It was
But it
almost
didn't
like I
work
had
either.
water. No, well you say that it did. I think it was either that one or Stellara, one or the other, because I had them back to back, didn't I? It was one of them. Got rid of my cyst on my ovaries that I'd had for years. So it did something. It just didn't do what we wanted. it
Yeah. so there is a really good reason for switching from biologics. So if vedolizumab hasn't worked, you can have infliximab. It might work really well for you because it does work on a different sort of,
I have to say,
completely
it
different
was
way.
the only
just
drug
like
that
azathioprine
worked for me was
does. Yeah.
infliximab, but unfortunately I then became allergic to it. So.
However, there is plenty of evidence to suggest if you start circling, if you go down all the biologics, by the time you're trying 4 and 5, it's unlikely. Well, it's less effective. It's less likely to work if you're hitting 4 or 5, 6 biologics. If your disease is that difficult, and it tends to be, this is why we tend to push people with ulcerative colitis to surgery if they've had 5 or 6 biologics. Nobody wants to be immunosuppressed like that all the time forever, and a lot of people will say, actually I do want surgery now, and secondly they become less effective as time goes on. But it's always worth switching them, because some people do brilliantly on one drug or not the other.
We need to wind up because we're already 10 minutes over, but we did start.
But we
back.
did start late,
late,
yeah.
we did
But we've
start
got a
late.
couple more questions if we can do it a bit quick. Hannah has said, any tips on recovering? My Barbie butt is getting very itchy.
Oh,
Pseudocreme.
pseudocreme's brilliant.
I mean, I use pseudocreme for everything.
Yeah,
Yeah.
it's an old-fashioned thing. It's fantastic. So I personally, again, old-fashioned sits baths.
Sitz baths are amazing.
Taking it
yeah.
really easy, Hannah. I know that's going to be impossible for someone like you,
Epsom
and
salt.
you've got your youngster to look after.
I always found I've not had the Barbie butt yet, I'm sure I'm heading that way. But with anything healing, I found the Avon Skin So Soft, the original,
brilliant.
was absolutely
Brilliant
amazing.
stuff. Yeah.
Not only did it stop irritation, it actually healed the like barely any scar from afterwards as well. So
Samantha
Right,
Averill, she's my colleague. Hi
Yes.
Sam, she's a wonderful nutrition nurse. Having Paula joining the team is going to be so good. She's
Thomas.
depressed because she's leaving.
Thomas.
No, Paula's leaving the nutrition team.
Oh, I see.
And Thomas, can you do anything about the Cono-S anastomosis? The short answer is no, Tom.
But
I do
studied
know
at
about
Hereford.
I do know about the Cono-S anastomosis study. I don't know enough to tell you much about it.
But we can find out for the next one.
You can, and what I can do is I can get Walter Dewey to tell you all about it. It's a new type of anastomosis of the bowel that leads to less recurrence later on, and they're doing a study at Hereford into that, and Mr. Dewey's running it. So,
Is there anything that we could publish? We could post on Facebook about it.
I don't know because it's a study, so
Oh,
it
right,
might
not
be.
reported yet.
But Mr. Dewey can. He loves talking about cono-anastomosis, so I'll get him to email you, Tom.
Tasha says, what are the side effects with biologics?
they all vary.
Yeah.
Everybody's different. It's
Most
so
people
difficult.
tolerate them really well. I would
Yeah.
say most people tolerate them better than azathioprine and mercaptopurine.
Yes.
And steroids, most people tolerate them better than that. There's not, with any drug, there's a huge list of side effects, isn't there? Even if you look at paracetamol, there's masses. But on the whole, they're a really well tolerated group of drugs, and they change people's lives for the better, without a shadow of a doubt.
Yeah.
Yeah.
No, absolutely. It's yeah.
Thanks all. I'm taking it easy as this has been the worst operation. Mr. Dewey is the best. And did Stacey just put something?
Thomas did a laugh, he said, and he did tell me, but it went over my head.
Went over mine as well, Tom.
Yeah.
Stacey said thank you. I'll send out some. Thank you, Stacey. That's kind.
Yes.
Lovely. Okay. Brilliant.
So I think wrapping up.
Yeah.
Wrapping up. Is everybody happy? Sorry, it's a bit of a. Should we extend them? 40 minutes?
Yeah, we could do 40 or 45.
Yeah, if you don't want to hear
we
more,
have
then
in such a
45.
rush, don't we? All the
We
time?
are always in a rush. I
But we
think
don't get questions before, and we don't know if we're going to have enough
That's
seekers
true.
going.
if
Yeah.
you can send us questions before the Facebook Live, we can extend them, we can talk more, we can answer more. But when we haven't got enough coming in before, we don't know if it's going to take that long, so we just keep them
Yeah.
short.
And
So-
Stacey and I were talking earlier on that she'd be interested. I'm dumping her in it now. In maybe joining us for one.
Absolutely.
Because it'd be really good to
yes,
have
yes,
I'm stomach
yes,
wouldn't it?
Absolutely,
Please,
Yeah.
absolutely, yes.
Yeah.
Or Amanda.
Yeah.
Mr. Dewey loved
I was
talking
gonna-
about it. So just,
Mr. Dewey loves talking.
who's sticking your mouth?
We did
Stephen?
have the Stoma nurses once, didn't we?
Yeah, you did, yeah,
And-
yeah.
yeah.
Long
so-
time ago.
long time
Speakers,
ago.
I mean, Stacey, Samantha, Amanda, are these all people who we would welcome?
Yes.
Yeah, absolutely.
Yeah.
Please, yes. 'Cause-
Amanda's got 400 children, so she would have it quite difficult to get here, I think, at this time of day. She would have a breakdown. And Sam might be having a glass of wine. But no, absolutely.
Oh, yeah.
That would be true, though. I think getting someone from the nutrition team would be really
They would,
helpful.
yeah,
Definitely.
absolutely.
Yeah.
Yes, please.
Thank
Stoma
you.
nurses as well, please.
I hope you're all impressed that I'm drinking water tonight.
I'm disappointed I got special wine in for Kathy.
Bye, everyone.
Bye. Thanks, guys.